So hello, everybody. It's great to see you tonight. Thank you for coming to our session. Let me start off by sharing my screen. Get your welcome on here. There we go. So welcome to our International E3 Summit. My name is Eileen Michelli, and I'm the Chief Program Officer for the Marfan Foundation. I want to introduce you to my colleague, Helene Baruch, who is going to be in the chat box with you tonight, sharing some links and some relevant information to our talk tonight. Welcome to the third week of our summit. And it's being put on by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation and the VEDS Movement, and our partners at CERN. Before I go on, we have a welcome from our President and CEO, Michael Weimer. Michael, would you like to say a few words?
Sure, thanks, Eileen. Good evening, everybody. It's nice to come back by again tonight to be part of another one of these sessions. I will tell you that you know, they always save some of the great acts until the final days, right? And we're really honored to have Dr. Svensson with us this evening, not only representing, you know, the foundation and this great program, but as an extraordinary surgeon from the Cleveland Clinic and chairman of their institute there. And they're extraordinary friends, actually, the foundation as well. They're major walk supporters. We've had medical symposiums with our friends in Cleveland. And I must say that I recall them having the greatest medical symposium brochure that I've ever seen. So they have another record as well. And also Dr. Roselli and Dr. Zaka have been very good friends of the foundation as well. With regard to the summit, you know, we are, I'm sure by tonight we have passed the 5,000 mark. We've had 5,000 plus viewers of sessions, 70 presentations, 95 speakers, 7 languages. It's been an extraordinary journey, and without folks like you attending these sessions, you know, it just wouldn't be possible. So thank you for everything you've done. The foundation's honored to be part of this, and we have a wonderful program, this heart-to-heart chat this evening. So Eileen, back to you.
Okay, well, we really are making history. Michael talked about the number of views that we've had of our sessions. We are just, I'm sure we've hit, between the time I made this PowerPoint earlier today and now, I'm sure we've hit 2,800 registrants. It truly is historic, and we hope you've had an opportunity to connect with people all over the world in the app, and that you can maintain those connections after the summit. As you surely know by now, you are not alone on this journey, and we are happy to help you connect with other people with the same diagnosis. We want to thank our presenting sponsors for the International Summit, Brigham and Women's Health Hospital and American Communications Construction. Because of their support, we are able to provide this, this great opportunity to you to hear from the experts from all over the world. Tonight, we have a special session sponsor, and that is Cleveland Clinic, which is the home of our speaker tonight, Dr. Lars Svensson. And as Michael just said, Cleveland Clinic is a huge supporter of the Marfan Foundation. You can learn more about them in our exhibit hall. There is a virtual exhibit hall where you can learn more about Cleveland Clinic. And we certainly are grateful for their support for this event and throughout the year. So I just wanted to share this one little, if you haven't heard this before, I do want to let you know that the International E3 Summit is a forum to provide an open discussion of issues related to genetic aortic vascular conditions. The opinions stated here during these talks are the opinions of the speakers and not necessarily those of the Marfan Foundation or CERN. And if questions arise or clarifications are needed about differences in opinions between session speakers, please contact our help center at marfan.org/E3Ask. So before we have one more piece of business before we get to our presentation tonight, and this is about your feedback. So after this session, we do want to know what you thought. We want your opinion of this session, and you can do that by going into, we're right there on your app where it says rate. If you click that, then there'll be a few basic questions and you give us your feedback. In addition, tonight, our complete survey on the E3 Summit is going to be available. So whether you've attended one session or 20 or 30 or 40, We want to hear from you. Your input is invaluable to helping us build future programs and services that meet your needs. To show our appreciation for your responses, 3 E3 Summit survey submissions will be selected at random to win a $50 US prepaid international debit card. So don't wait to submit your survey. Get it done this weekend. Only surveys submitted by 11 p.m. Eastern on Wednesday, September 16th will be eligible for the drawing. So the survey can be accessed at marfan.org/E3 survey. The link is also going to be on the homepage of the summit in the app. So we're going to have Dr. Svensson on with us shortly. And in the meantime, we're going to watch his presentation.
Well, hello. It's my pleasure to join you to talk about Marfan syndrome, which has been a long interest of mine since I was in high school, and a friend of mine had Marfan syndrome. I'll be covering a lot of aspects. I fully realize that patients with Marfan's do have a lot of understanding of Marfan syndrome, and I've often found they know more than their doctors too. And so I will dig into some of the details, but I'm going to talk about mainly Marfan's, about some of the other connective tissue disorders, and then in particular what's become very important for us is root surgery, because that's really what's changed the management of Marfan syndrome and particularly improved the long-term survival for patients with Marfan syndrome. And I'll touch some of the aspects of what the result has been with doing prophylactic surgery on the aortic root in patients with Marfan's. So just by way of background, the Cleveland Clinic, we do a lot of cardiac surgery. We're one of the biggest cardiac surgery programs in the world. Last year, we did 5,300 heart operations, and about 20% of those on the aorta. Our results are run typically at half the predicted mortality rate of other institutions, large academic institutions. And when it comes to valve surgery, we have superb outcomes. And as you see in green there, for isolated aortic valves, and up until recently, we had had no deaths for 2 years. And we do about 400 isolated aortic valves. And we haven't had a mitral valve repair death now for several years. So that just gives you some idea of what we do. And here's just the depiction of aortic valve replacements with no deaths for 2018 and 19 and half the way through 2020. So we are among the few programs in the United States with 3 stars for all heart operations and, for that matter, 2 thoracic operations. And last year we did 1,371 aorta operations, which is the biggest program in the world. About 800 of those are on the thoracic aorta. And last year we did 139 aortic root operations with preservations of bicuspid or tricuspid valves. In fact, by December of last year, we'd done over 1,000 re-implantation operations without modification. And there are really only 3 of us in the country who regularly do re-implantation operations, and I've done the majority of the re-implantations here at the Cleveland Clinic. So what we'll cover is Marfan's, a bit on Lois Dietz, a very little on Lois Dietz, and I'll talk a bit about bicuspid valves. It's not necessarily considered always a connective tissue disorder, but it is inherited, and a lot of the principles apply to bicuspid valves and Marfan syndrome. The prevalence of Marfan syndrome, the highest prevalence has been reported to be 1 in 5,000, and that is supposedly in China, but there's some variation on that. The average life expectancy in 1972 was 32 years because of aortic dissection, and I'll show you some data later that based on our data, the life expectancy with re-implantation operations in patients with Marfan's approximates the normal life expectancy for gender and age in the United States. So Marfan syndrome patients, obviously a high incidence of aortic dilatation, mitral valve prolapse is common, particularly in women, and then valvular heart disease. So this is the first publication of note that I wrote on Marfan's back in 1989 in Circulation based on 151 patients with Marfan syndrome operated by Stanley Crawford in Houston when I was a trainee there. And what was interesting in that series was that we used again criteria for diagnosing Marfan's, but there were some patients who had one or two criteria, so they did not meet the full Marfan syndrome diagnosis, but something was going on that looked like Marfan's but was not diagnosed as Marfan's. And now we understand that some of those patients are Loeys-Dietz or also inherited connective tissue disorders like the thoracic aneurysm disorders. So Loeys-Dietz, we now know there's a specific mutation for that. And what's different with Marfan's and Loeys-Dietz is the Loeys-Dietz patients tend to have more tortuosity of the greater vessels. And the bifid uvula is often described, but it's not often seen. And here you see the two sort of parts of the uvula in a patient with Loeys-Dietz syndrome. We looked at our patients with Loeys-Dietz a couple of years ago. We had 53 patients, and most of them had re-implantation operations. But the big difference in the patients who had dissection versus no dissection as far as survival, and this is somewhat mirrors what in the paper I wrote about the Marfan patients. So one of the things that has been debated, and I don't think it's entirely solved, is at what size to operate on patients with Loeys-Dietz. Diana Milowitz and I, when we wrote the thoracic aorta guidelines for AHA-ACC, said that probably somewhere around 4.2 centimeters we should be operating on patients with Loeys-Dietz, so in other words, a diameter of that. And in this series, that was more or less what we did. And we're not aware of having lost any patients with Loeys-Dietz using that criteria. Of course, we don't know what would happen if we'd waited to a bigger size, but at least the results were good, and we had no deaths in patients who had reimplantation operations. Ehlers-Danlos is quite different, and that's a collagen disease. And we have a small series of those patients that we've operated on. We don't know when best to operate on these patients, and we take into account family history of aortic dissection. So the other thing in this series of 151 patients from historically was that a lot of those patients ended up getting huge extents of their aorta replaced because of aortic dissection. And the 5-year survival was 74%, driven largely by the aortic dissections and chronic dissections and requiring multiple operations. At that time, we put in a lot of mechanical valves, and I wrote a paper on 348 patients with composite valve grafts. And the downside of the composite valve grafts is the risk of clot formation on them. In fact, if you look at the data at 10 years after surgery, about half patients will have either died or had complications of mechanical valves in the younger population. So we started repairing valves, shown in blue there, and trying to keep them much more, and we'll show you some of the details. So the way we keep valves, we prefer to reimplant them within a tube. This happens to be, I've had 6 patients who have been or are NBA players with large roots, and this is one patient who's still playing for the NBA with a large root, and this is a particularly big valve, and I've had other professional players too. But this is one way we repair the valves with a reimplantation operation. And then also the bicuspid valves, we either remodel the root or reimplant them. And here are just some of the techniques we use for either operation. So there's the Cabral suture at the commissures, and then this figure-of-8 suture that I've been using for patients with bicuspid valves and during reimplantation operations, where I use that to suspend the commissures at a higher level. There's, you see another step in that where the sutures placed on the outside. And yesterday I had a patient who had a complex reimplantation where I managed to get the valve to work by doing this figure-of-8 suture to suspend the commissure higher, and then I plicated his right leaflet also, and that resulted in a perfect valve with no leakage, having started off with 4+ leakage. Here's just an example of bicuspid valves. That's the Cabral suture there, and then a completion of the incomplete fusion of the bicuspid valve that's been sewn together. And there you see the figure of 8 at the commissures to suspend those leaflets. And this is a different patient with the figure of 8 suspension sutures. And this is the remodeling operation where we're going to sew to the cut piece of the aorta. And there's the modeling operation where the graft is beveled to fit the valve. So in 728 bicuspid aortic valve repairs, nearly half of those patients had severe aortic valve regurgitation, and close to 40% of those patients also had aorta operations. The results were really good, mortality rate of 0.4% in that series, and the survival at 15 years was very good, about 90%, 10 years, 94%. So this approximates the US expected survival in patients who've had surgery. Gradients do tend to increase in time in bicuspid valves, but of the 105 patients that we reoperated for various reasons shown here, there were no deaths with reoperations, so no penalty from the point of view of risk of death with repairs, but obviously requiring a second operation. And freedom from reoperation in this series was overall about 80% at 10 years. But as I'll show you, as we've become better at this, the results have become better over time. So in the more recent operated patients, the freedom from reoperation is much better. So when should patients with Marfan's or bicuspid valves be operated? So when I was in Boston, we did a study looking at our Marfan patients and the risk of aortic dissection. And it turned out 15% of our patients dissected at a size less than 5 centimeters, and these were predominantly shorter patients and women. Turns out this is exactly what Vincent Gott also found in the historical Johns Hopkins series of Marfan syndrome patients. Just to point out as an aside, we have now operated over 1,000 patients with Marfan's, which is now the biggest series in the world of Marfan operations. So in that series, giving some thought to how do we correct for the patient's height, this is the formula that we came up with, which is taking the cross-sectional area of the biggest part of the root typically and dividing by the patient's height. And if that was more than 10, we considered that as a criteria for operating on patients. And that then took into account a shorter patient with Marfan's. So for example, a 5'6" patient with Marfan's, we'd operate at 4.7 centimeters, whereas a 6'4" male typically we'd operate at 5 centimeters in those patients. So here's the relationship between height and dissection, size as a diameter, and that's the ratio. And you see that if you use the ratio, then the effect of size is taken out of the calculation. So this made it into AHA and ACC guidelines on management of thoracic aortic disease. And one of our cardiologists then took also all our CAT scans and looked at cross-sectional area and the risk of death over time. In the purple bottom line there, if a patient had a ratio above 10 and did not have surgery, the risk of death was very high in that particular series. So let me run over some of the guidelines. So as I mentioned, Diana Milowitz and I gave some thought to Lois Dietz and went to operate on those patients. We kind of, I wouldn't say we punted, we had fairly good evidence to suggest that 4.2 centimeter was a reasonable size to operate on patients with Lois Dietz. And as I showed you, the results have been very good. When it came to women with Marfan syndrome and pregnancy, we recommended 4 centimeters. I'll come back to that a bit later. And then for patients with genetic syndromes and Marfan syndrome in particular, we recommend a ratio of 10 or 5 centimeters for operating with Marfans. And then we put in some recommendations about Turner's syndrome. And the reason for the use of the ratio of 10, as I pointed out, was the risk of dissection less than 5 centimeters in shorter patients. And then lowest needs some variability then when to operate on patients. And we put this into a guidelines that was published in Annals of Thoracic Surgery, that bicuspid valves should be operated more than 5 or a ratio of 10. So the WHO came out with some recommendations as far as pregnancy, and in patients with pregnancy planned, they recommended patients should have prophylactic surgery at 4.5 centimeters if they had Marfan syndrome. One of the things that's often not understood about Marfan syndrome is that they can have localized tear without a full-blown evidence of dissection. And over the years, those of us who've operated a lot of Marfan patients have seen this. And we'll sometimes see patients who've healed local tears. That's a type 3 class there. It's something that we described many years ago. And then on top of that, they get full-blown dissection, the classic type 1s. And here's just an example of a patient who came in with classic dissection symptoms, was discharged from the ED, came back again. We cathed them and did a root angiogram, saw this sort of ectopic area of asymmetry in his root, and he had this localized tear. Here's another patient with a bicuspid valve, and you see there also a localized tear right next to the left main coronary artery. So it turns out, based on the data we had, that it seems to be a bit more common to have localized intimal tears in Marfan syndrome patients. Let me talk a bit about elephant trunk procedure. So many of you have heard about that, and that refers obviously to the elephant trunk, and it floats loose in the descending aorta for subsequent operations. So the way we used to do that in patients with dissections, we'd open up the dissection, sew the elephant trunk into the aorta beyond the artery to the left arm, and then reperfuse with a side graft, and then do the completion of the repair. And the later operations depended on the extent of the dissections and the aneurysms. So one of the big issues with arch surgery is the blood supply to the brain has to be shut off to do the arch operation. And we did a prospective randomized trial looking at various options in protecting the brain. And in summary, 39% of these patients were redos, 61% had elephant trunk procedures, and the overall mortality was only 0.8% and stroke rate 0.8%. And interestingly, there was no difference between antegrade versus retrograde brain perfusion in the study. And we looked at MRIs and also neurocognitive function. And here's the neurocognitive this is the blinded imaging studies, so MRI studies showing no change with this approach as far as injury to the brain, and comparing the various approaches also. So for a period, I did this very extensive operation where we replaced the entire aorta during one operation. And I'd hoped that this may be an alternative to the elephant trunk procedure. Here's just another illustration of a patient. Unfortunately, the risk of death was 17%, so it was too high. And we went back to modifying the elephant trunk procedure and ended up making it a lot safer. But this is just the approach of the very extensive operations we used to do. And as I say, we don't do this any longer, but it certainly was feasible, but the risks were very high. And this is the first patient we did where we replaced the entire aorta from the aortic valve down to the bifurcation. And he lived many years after this, taking only aspirin as a medication. But this is a patient third time redo with Marfan's, and shows some of the things that we think are important nowadays, which is debranching the arch, the elephant trunk procedure, clips on the distal elephant trunk. And in this patient, because he had a mechanical valves, we'd put in a composite mechanical valve. So we've classified the elephant trunk procedures based on also when stents are put into the descending aorta at the time of surgery and where the proximal anastomosis is done. And then a lot of these patients also have stents in the descending aorta and as part of the repair. When it comes to the acute dissections, we've increasingly used stents in the aortic arch also to try and reduce the risk of subsequent operations. Here's just an intraoperative operation. Hopefully for those of you who are not physicians, this is not too gory for you, but I apologize if it is. But here's a elephant trunk procedure with the, on the left, the debranching to the greater vessels. Here's another version, a similar operation. That first operation was a 22-year-old, and I'll show you more images of that later. And then the patient I showed you earlier with Marfan's, we then used multiple types of procedures, both stents and operations, to replace the rest of his aorta down to the femoral arteries. And I still get cards for follow-up from him. He's actually a professor of physiology, and he's done very well long-term. There's another image of that. So for second stage elephant trunks, we will sometimes put in a stent graft to complete that repair. Here, I'll just show you the clips on the end of the elephant trunk and a pacing wire that we use to straighten out the graft. And here's a second stage with that in place. And here you can see that pacing wire, and then the clips are also here. So that helps us with markers as far as where to place the stents for the second operation. Roy Greenberg and I went through a phase where we were looking at stenting the descending aorta, thoracoabdominal aorta, after defunctioning the mesenteric vessels from the iliac. So I do these bypasses, and then Roy would stent the rest of the aorta. Here's an example of a patient where we did that. Not an ideal operation, so we went back to fenestrator grafts, as we call them, and branch grafts. But here's another example of a patient with a leaking thoracoabdominal aneurysm, but also severe AI. Put the elephant trunk in, wrap the aorta, and then put a stent into that wrap. And here's the procedure being done with a stent, and there's the wrap and the descending aorta, ballooning that in position. And here you see this extensive metal jacket. Here's the CAT scan showing the second stage operation. Here's this 22-year-old I showed you. So we put a tailoring sort of elephant trunk down here below the viscerals. And so it was very easy then to just put a stent into his bifurcation down to the iliac arteries to complete his repair. So getting back to the ratio issue, we looked at our patients with bicuspid valves, and for root patients, the hinge point is somewhere around 5 centimeters when the risk of dissection increases. For ascending aorta, it's about 5.2, 5.3 centimeters. And when we looked at all the predictors of dissection, the ratio was the best predictor as far as risk of dissection. And that was based on looking at all our patients with an aorta above 4.7 centimeters with bicuspid valves. 800 had surgery, and the 800 had surgery, the risk of death was 0.25%. And the patients who were surveillance, it was dependent on what the size of the aorta was for the time period for them requiring a operation. So the bigger the aorta, the bigger the risk of dissection and the bigger the reason for operation. So let's talk a bit about what I look at when I do a reimplantation. To make a successful repair, you have to look at the commissures, the leaflets. Obviously, you don't want leaflets with big holes in them. The annulus, you want to bring the annulus down to a normal size. You want to create artificial sinuses, and then a sinotubular junction to have a successful reimplantation. So these are all the things that are critical. Here's a patient where you can see the dissection plane. So this happens to be a patient with Lowe's Dietz, and you can see how the layers just peel apart in these patients that we do prophylactic surgery in. Unfortunately, this is a Marfan patient with two long gone and big holes, and this was not a valve that was preservable. So the way I like to do the modified reimplantation operation is I use pledgeted sutures in the left ventricular outflow tract, and my colleagues who do a lot of these operations now have also gone to using pledgets in the left ventricular outflow tract, particularly in Marfans and Lowe's Dietz, because these sutures can pull through, and even Tyron David has gone to using that in patients with Marfan syndrome. So here's a valve that's been dissected out. It's very important that the entire valve sits inside the tube graft. Otherwise, there's a risk it will pop out, and then you get regurgitation and problems. So particularly in the right ventricular outflow tract, it's very important to get low. And here's a valve now with the sutures in the left ventricular outflow tract, getting ready for reimplantation. Here you see the pledgets in the left ventricular outflow tract and the nice looking valve there. There's another picture of that. And then I tied down around a hay gauze so that this is normalized to the expected size annulus for a patient of that height. And that, I believe, has been a contributor in our much better long-term durability of these valves. So in one study that we're hoping will get published soon, our freedom from reoperation for all our reimplantations when we were up to about 600, 700, was 97% freedom from reoperation at 10 years. In other words, a 3% failure rate. 15 years, it's probably going to be 92 to 95%. In our Marfan patient, and I'll come back to that, our freedom from reoperation for reimplantations in Marfans was about 92%. The more recent data is looking even better, and we reanalyzing our patients. So here's what you hope to see: a nice 3-leaflet valve, nice symmetry, and about 2 to 5 millimeters of apposition of the one of the NBA players and his valve, and a big valve, and again, good results. And then we hook up the coronary arteries, and then depends how much we have to do for the arch to repair that. Obviously, as I mentioned at the beginning, a lot of Marfan patients have mitral valve disease and Barlow's valve in particular. And so here's a patient with caudal transfer, caudal lengthening, and not lengthening, but artificial chordae with Gore-Tex and complex repair. There's the repair before the reimplantation operation. And so this is some data. We looked at our patients who had combined reimplantation and mitral valve repairs, 53 patients, and in orange up there, we had no failures in the patients who had the combined operation. So a pretty reliable operation in this group of patients. Now note that at 10 years, the freedom from reoperation is 97% in this particular study. So some procedural aspects, as I mentioned, we use the hay gauze, and that's not related to cause any problems. This is freedom. This is an older paper. The reimplantation operations had the best durability when compared to other methods. And sorry, that was survival. Here's the reoperations. Reoperations risk was low with all the operations, but bicuspid valves had a slightly greater risk of reoperation at 91%, eventually at 10 years. If we looked at the underlying problem, interesting, Marfan syndrome had a very good long-term outcome as far as a risk of reoperation as aortic dissection and degeneration, but as I mentioned, the bicuspid valves had a higher risk of reoperation. A long time ago, we looked at patients with Marfans versus Marfanoid patients and remodeling failures, and that occurred in Marfan's patients. And so the remodeling operation, we don't use that in Marfan's any longer because the failure rate with that operation. So the number of patients that we do reimplantations on has increased tremendously over time. And as I mentioned, we're over 1,000 patients as of December last year. And in Tyrone David series, 167 patients, the mortality rate was 1.2%. I'll show you some of our data. And our freedom from reoperation is running now at 97% at 10 years. So clearly this is a safe operation in Marfan syndrome, and it's something that's a very valuable way to treat patients and preserve their valves. So a couple of other things to talk about is the particular operation in the series of patients with connective tissue disorders. So these are the connective tissue disorders we looked at. We had 178 patients. So this is a series now that's nearly 10 years old. And as I say, we're updating this with 178 patients. And most of them obviously had Marfans, and the regurgitation degree was actually quite severe in some of these patients when we were able to keep the valves for them. And so, like I showed earlier, we use those pledgeted sutures, reimplant the coronaries, hope to get a nice symmetrical valve. The percentage of patients who had a CABG was pretty low, and then mitral valve repairs sometimes. So as far as outcomes in that series of 178 patients, we had no deaths with connective tissue disorders and reimplantation. It is more tricky in patients with connective tissue disorders because the tissue is fragile, so one has to be careful. So this is the older data, 94% survival at 8 years in that series, and freedom from reoperation, 92% at 6 years, and as I say, it's better. And these were the failures. Interesting, some of them were endocarditis, which I didn't expect. Sometimes it gets really complex. Here's a patient who had aortic dissection and gut ischemia, and we first put in a stent graft in the descending aorta. You can just see a bit of it there. Then I did an elephant trunk procedure for him, did a reimplantation of his root. And by the way, I had seen him in consult when he was about 6 centimeters for his aortic root and recommended surgery. And he decided not to come back for surgery until he had the aortic dissection, and then he came in to see us. Fortunately, he survived that, and then here's that reimplantation, the elephant trunk procedure, and we hooked that up for him. So certainly things can get complicated. Let me talk a bit about valve durability repair. And so we looked at our patients with various operations, so separate valve repair and ascending, the reimplantations and the remodeling operations. 1,000 patients who had valve repairs. We used a lot of different techniques to repair the valve. And in that series, the risk of death was just over 1%. In the contemporary series, the results were a lot better, with freedom from reoperation at 90%. So this is all our valve repairs. And we also compare that to our historical data, where the data for the most recent patients, risk of reoperation was much better. In patients where we used that figure of 8 suture, the freedom from reoperation was much better than those who didn't have it. When we did a full root repair, like a reimplantation, the durability of the repair was much better. And then, as I mentioned earlier, if we matched that to age, sex, and race in the United States, the survival was very similar to the matched population. So when it comes to repairs, we believe bracing the root and figure of 8 sutures are important. Now, sometimes, unfortunately, we have to do full root replacements and repairs. And so we looked at 957 patients comparing the various root procedures. And here you have them, the homograft or allografts, composite mechanical, composite biologic, and valve preserving procedures. And obviously, we're seeing a lot more biological bentols for the hope of TAVR, and also we continue to do, obviously, a lot of valve preserving procedures. In that series, the overall mortality rate for root procedures was 0.73%. He has a survival over time, which is pretty good, out to 15 years. He has a survival by the procedure. Interesting, valve preserving and Bentols had the best, so Bentol mechanicals. And that's why I think for most people with Marfans who are young, who have a big root and the valves are not repairable, and I usually tell patients about 95% of the time we can keep your valve for you unless it's torn to pieces. The mechanical composite is a very good option. He has a presence of regurgitation over time. Valve preserving is a bit higher with leakage, but on the other hand, the gradients across the valve preserving are very low. These are the risk of reoperation in that series. So 70 patients needed reoperations. Valve preserving is because leak. Composites is usually endocarditis. Allografts is usually failure over time. And he has the freedom from reoperation. That series, about 80% at 15 years. He has the freedom from reoperation by the underlying operation. And again, composite mechanical valves do hold up very well. So one of the questions, obviously, for somebody having a prophylactic reimplantation operation is, what is the risk, once you've had that operation, of having a de novo dissection down the road? So we looked at our patients, and it turns out for 664 patients who had valve preserving operation, the risk of that was 1.4%. So pretty low risk, slightly higher risk in patients with Marfans. And when we looked at how we treated those patients, and it's usually a descending dissection, it really didn't make any difference whether we treated patients medically or surgery. So we usually initially treat patients medically and then watch them, and if need be, if they develop aneurysms in the descending aorta later, then we certainly can either stent or operate on them. So mechanical valves, still a good option, and whether the newer NOACs will be an option, for example, Aliquest, remains to be seen. One question that sometimes comes up occasionally, what about having a homograft or human valve instead of a pericardial valve? Our data show there's no benefit for that unless a patient has endocarditis. So these operations can be complex. They are technically more demanding, and you're flying in close formation here with a complex situation. Better have an idea of how to get out of trouble if things go wrong. And my backup operation has always been to do a homograft if a reimplantation doesn't work out during an operation. And fortunately, touch wood, so far, I haven't had to do that. So that's a summary of the reimplantation and root surgery. I think we've come a long, long way from the days when I trained in Houston, when we were putting in a lot of mechanical valves. But on the other hand, the mechanical composite valve graft in a patient who cannot have a reimplantation is still a good operation. The reimplantations are holding up much better than we expected. Certainly, we were very concerned with Marfans and myxomatous leaflets that they would fail over time, but they're actually holding up very well. And so if 5 out of 100 patients need another operation within 10 years, I think that's a really good result. And with over 1,000 patients with reimplantations, we're going to be able to produce some more manuscripts looking at the long-term durability of the reimplantation operation, and including, as I mentioned, patients with connective tissue disorders and various aspects of these reimplantation operations. So I hope you found this informative. I know a lot of you have Marfan syndrome or have family members and are interested in this. And there are also a number of physicians who are on this virtual meeting and have been following that too. And the description I wrote up many years ago on how to modify the reimplantation operation really seems to be holding up very nicely. So thank you very much for your attention. I'm always available if you'd like to contact me at the Cleveland Clinic. Thank you for this opportunity.
Wow, that was incredible. Thank you, Dr. Svensson, for that incredible presentation. Put my video back on so you can at least see me. So the good news is we do have Dr. Svensson here. We are just trying to get his audio working, but Kelly is on the case with that. And so
I'm on now, so I think you can
Look
probably
at
hear.
that. The magic of technology. Thank you so much. That was a great presentation.
Thank you very much. It's my pleasure.
So we have a lot of questions for you here. So we're so glad to have you. So
Sure.
okay, to start with, God, I don't even know where to start here. So question about mitral valve repair. Do these repairs deteriorate over time and eventually require re-repair? Are there minimally invasive techniques for re-repair?
So let me answer that two ways. As you saw, for our patients that had combined re-implantation and mitral valve repair, at the time of that study, we had not had any re-operations. Now, if you're talking about Barlow's valve, which is typical in Marfan's and connective tissue disorder patients who don't have a big root, yes, those can be done with a robot. So that's robotically assisted, and that requires 4 ports. And the results with that have been superb. And as I mentioned, we haven't had a death from a mitral valve repair since several years ago, September 2016, I believe it is. So those patients who only need a mitral valve, we do robotically or minimally invasively. It depends a bit on what needs to be done. For example, if a ablation needs to be done, a maze procedure for atrial fibrillation or coronary artery bypass, I usually do a minimally invasive, what we call J or L incision for those patients, and that's how we manage that. Now, as far as doing a re-operation with a minimally invasive method, there was a period when I did that with what we call the J incision, but we went away from that. We don't do robotic repairs, but we will obviously open up a patient's chest to do a re-operation, and some of those are re-repairs. We've just found that to be safer for an operation that can sometimes be complex.
Okay, great. Thank you. Somebody heard something in the presentation. I think you need to clarify this. They're asking, did you say that half of patients with mechanical aortic valves are dead within 10 years? I don't think you said that.
No.
So clarify that.
No. It's the freedom from all events. So that is freedom from bleeding, freedom from embolic events, freedom from reoperation, and death is one of those. No, the risk of death that runs at about 5-10%. It's very age dependent, and what the original risk was. And there actually are some studies from Europe that in patients who have mechanical valves put in young people, the survival matches the general population. So, no, sorry if I made a mistake in what I said there. It's the freedom from any event.
Yeah, it was a lot of numbers, so I can see how people might
Sure.
get lost in that. But no, thank you for. It was important to clarify. This is a little bit. This is an aortic surgery question, but a little bit quality of life related. Are health professionals cognizant that aortic surgery patients need counsel about resuming sex lives? Is that something that you talk to patients about?
I don't start off or volunteer that, but from the point of view if a patient asks that, what my advice is wait 6 to 8 weeks in patients who've had full stenotomies, because it takes about 6 weeks for the breastbone to heal up again. And as a general activity situation, a patient's body is going to tell them if they're overdoing things, and one's got to be careful initially about putting pressure or stretching the wires in the sternum while somebody's healing up. So it's the general idea that avoid strenuous activity for the first 8 weeks, but we encourage people to walk. And what I tell patients is try and walk 45 minutes a day, 5 times a week, and that's very good exercise. Cardiac rehab, I think, is important for a lot of patients too. And in the United States, the government does sponsor for a lot of patients cardiac rehab after cardiac surgery.
Right. Yeah, I was going to say that question probably is also like any other very or similar to other physical activity after surgery. It's about the the intensity and and competitiveness.
Sure.
And all. So yeah, we'll end it. We'll end that one there. Are there warning signs in scans or symptoms a person might experience to indicate that surgery might be needed again after earlier ascending and arch replacement?
That's a very good question. And unfortunately, when it comes to warnings, there are very few warnings in patients who have a connective tissue disorder. If anything, we have, this is fairly old data now, but patients with Marfans can often have silent dissections. Everybody knows about the severe pain with aortic dissection, but Marfan patients seem to be a bit more prone to have silent dissections without pain. The other big issue is more historical. In other words, patients who've had aortic dissection or had major operations, they may not have been followed in the past as closely as patients are nowadays. And we generally encourage patients with aortic dissection to get a CAT scan or MRI, depending on age and what's involved, on a yearly basis or every 2 years. And the idea here is to pick up any growth of the aorta. Late symptoms can occur, like, for example, difficulty in swallowing or wheezing or paralyzed vocal cord. But those are usually with very big aneurysms, and nowadays those type of problems should have been picked up on an echo, a CAT scan, or MRI before they become a serious issue.
Great. Thank you. The next question relates to pseudoaneurysms. Should they be repaired or not? What's your experience with them? And is there any research that can guide this decision?
Again, a very good question, and it depends where it is and the size. So, for example, when we do acute dissection repairs, sometimes we will find there's a little pocket, and it's not really a true pseudoaneurysm by definition. It's an aneurysm within the wall of the repair in the aortic root. This typically wouldn't apply to Marfan patients because we usually put in a composite valve or do a re-implantation at the time of acute dissection repair. But at anastomoses, a true pseudoaneurysm means that there's no aortic wall on the outside of the aneurysm, so there's an outpouching. And then again, it depends where it is. Now, for example, historically, we used to see a lot of pseudoaneurysms at the coronary artery buttons with a classic inclusion technique, Bentall operations, and those we would reoperate and fix because we know those could cause problems. So it depends where it is, what the risks are. Occasionally, we will also stent a pseudoaneurysm, particularly if it's in a descending aorta. But if it's an elderly patient and high risk in the ascending aorta, and let's say, for example, with the distal anastomosis, then stenting is an option in that scenario also. So I'm not trying to dodge the question here, but there are a lot of issues that come into making a decision about whether to treat it or not and what the size is.
Yeah, this isn't stump the surgeon. Our people who are participating have very, very complex questions and very unique experiences, and so they really get to the nitty-gritty here. Somebody says if they've already had valve-sparing aortic root repair, but developed subsequent aortic insufficiency, can the aortic root be repaired and re-implanted?
Yeah, a good question again. As a general rule, when somebody comes back from a re-implantation and it's failed, we usually replace that valve. I have occasionally repaired a valve, but it is pretty complex. When it comes to the mitral valve, we do repair and re-repair those more often. But for the aortic valve, usually that means there's a problem with integrity of the tissues of the valve. And I mentioned the myxomatous valves. And some of the ones that we've seen that have failed have been from endocarditis. And in that situation, a re-repair is not an option. So in that scenario, depending on the patient's age, we either put in a mechanical valve or a biological valve. And if the biological valve, with the idea of potentially doing a TAVR, so a percutaneous valve implantation from the groin at a later stage. So as a general rule, re-repair I don't encourage, because it's already a tricky operation the first time around, and to do it again, I think adds quite a lot of risk. Now, I've done it, and it sometimes works, but I'm not a big advocate of a re-repair.
Somebody else actually had a question about a re-repair too, and this was more about the two types of re-repairs that you mentioned, the mechanical valve or bovine valve. So can you talk about the pros and cons for those two?
Yeah, so, certainly our data shows, as far as risk of reoperation and survival, mechanical valves do very well. We also realized early on with composite valve grafts that the risk of stroke long-term with a mechanical composite valve graft is lower than an isolated aortic valve. And the reason is because the sutures with isolated aortic valves are tied within the bloodstream, with a composite valve graft on the outside, so less risk of emboli forming or platelet aggregates on the sutures. Now, as far as mechanical valves, the one study that I'm involved with leading together with John Alexandra from Duke is a national study looking at the Onyx valves, both composite and isolated. And we have FDA approval for trial that we're enrolling now, that what involves is 3 months after the valve insertion, so in other words, when it's sort of healed into position, patients are randomized, sort of like a flip of a coin, to either stay on Coumadin or switch to Eliquis. And we think those risks will be reasonable. It's a study that will probably take us about 4 years before we have an answer to that. And we think that's reasonable. Now, as I showed in that data with the biological valves, there is a greater risk of failure over time. And the younger a patient is when they get a biological valve, the higher the risk of failure. So in a young person, for example, we sometimes would put in a biological valve for a young woman who's planning a pregnancy. That valve may last 5-7 years, whereas in a patient over the age of 65, the companies tell us that 80% of those valves are still working 20 years after surgery. And then on top of that, if they fail, there's either option of reoperation or having a TAVR put in through the groin, which is the other option.
Okay, thank you. At what point would aortic root repair be advised for a 70-year-old male with suspected Marfan? Apparently, this person has not had genetic testing, so the diagnosis has not been confirmed, but their daughter and grandson both have Marfan.
Well, based on that, I would say the suspicion would be pretty high that that patient has got Marfan's. Obviously, the genetic testing now for Marfan's is very good on determining that. But I would say if the aorta is more than 5.2 centimeters, something like that, depending on the person's height, and if the patient's otherwise in good health, I would recommend surgery. And I don't really have a cutoff for reimplantation operations. I've done it in 75-year-olds, 74-year-olds. It all depends on what the valve looks like. Obviously, somebody over the age of 70 with a valve with perforations or calcium, I will then lean towards putting in a biological composite valve graft.
Here's another age question. This is somebody a little bit younger, 44 years old. I believe they have Marfan and 7 feet 1 inch. If they haven't had significant aortic enlargement yet, do they have to worry about it in the future? Should they still be monitored? What?
Yes,
and
if there's somebody with, so the patient has Marfan's?
Yes, I believe so.
Yeah, so the spectrum of when patients need surgery who have Marfan's is quite variable. The majority of patients are obviously in the 40s or 50s, but I've seen patients with clearly Marfan's where, for example, I can think of a woman whose kids had Marfan surgery in their 40s and 50s, and she didn't develop an aneurysm until she was in her 70s. So there is variability there, but usually by middle age, most people will have enlarged the aorta. I would also say that if patients are found initially to have an aortic root of 4.5 to 4.7 centimeters with Marfan's and they're aggressively treated with beta blockers or valsartan or one of the newer medications, that will often hold the aorta stable for a number of years and prolong the period when they don't need surgery, and then later. But I think over time, I would think that most Marfan patients end up needing surgery if they live their 20 score on 10.
Yeah. Okay. So, I mean, this whole presentation was about advances in aortic surgery for patients with connective tissue conditions. What do you think what were the 2 greatest breakthroughs you think in the past 20 years that are available to patients with Marfan and Loeys-Dietz?
Well, clearly, prophylactic surgery has completely changed the disease, and that is a result of more patients having echoes, CAT scans, and MRIs. When I started off in cardiac surgery, the majority of our Marfan patients came in with aortic dissection, and nowadays it's completely reversed in the sense that patients with Marfans are picked up much earlier. People are much more aware of it. The genetic testing is better understood. Same with Loeys-Dietz. And so people have prophylactic surgery much earlier. So that's changed the whole profile of the patients that we see. The other thing is, I think we've got to give the Johns Hopkins team and particularly Dr. Dietz great credit for the wonderful basic science research he has done on understanding Marfan syndrome and the pathways involved in generating the phenotypes and the elastic tissue problems, et cetera, et cetera. I think that what's been disappointing is that although we understand the biochemistry and the physiology and pathophysiology so much better about Marfan's, the medications have not been as effective as we would have predicted from the pathophysiology. And so that is something that I think there's still opportunity, and we'll see how things evolve. But the big breakthroughs already improved detection, great surgery nowadays, and also better understanding of the pathophysiology.
Just to put in a pitch for experienced surgeons like you, Dr. Svensson, I just want to just to make sure everybody knows that these surgeries are definitely, are so much better now. It's always better to go to an experienced surgeon who has worked on connective tissue conditions, don't you think?
Well, thank you. Yes, I think that's very true. The tissues in patients with Marfan's and Lowe's-Dietz are very fragile, and I think everybody understands Ehlers-Danlos also is a situation where the tissues are very fragile, and one has to adjust also the operative procedure for patients with Marfan's versus Ehlers-Danlos versus a patient with Lowe's-Dietz. And the way I think of them is that although the physiology or the pathology of the aorta is quite different, the patients with Marfan's, it tends to be root problems and ascending aorta. Lowe's-Dietz is sort of in between Ehlers-Danlos and Marfan's in the sense that they often have branch vessel problems, and one's got to be very careful in the arch on operating on those patients. And then, as we know, with Ehlers-Danlos, the branch vessels are very fragile. And so there's the spectrum of disease, and one has to do these operations with great gentleness and care because things can get tricky pretty quickly.
Yeah, exactly. Before we go to some final comments, I just want to make a couple of comments about a couple of the other questions that are in here. Somebody asked about Pear's procedure, and we had an entire session on that earlier this week. So I would just encourage you to watch that recording and listen to that discussion. And then you could, if you have more questions, obviously you can contact us. Somebody else had questions about physical activity guidelines, like what sports are safe. And we do have a session on that this Saturday. So that's at 12 o'clock Eastern time. I don't know where you are, person who asked this question, but any more questions about physical activity after surgery or with the dissection or with one of these connective tissue conditions, I would recommend tuning in on Saturday. So before we close out here, I want to go back to my final announcements here, and then we'll have another word from Dr. Svensson. But again, I want to just remind you that if your questions weren't answered, please submit them to marfan.org/E3ask. That goes right to our help center. We have a nurse there, and give her a chance to get back to you because our volume is high. And if there are questions she can't answer, she can reach out to Dr. Svensson and try to get some more answers for you. I mentioned the session survey earlier this evening, as well as the survey about the summit. Your feedback will help us determine our next moves and what we can do for you. Also, I mentioned Cleveland Clinic as our session sponsor. They are in the exhibit hall, as well as our other exhibitors from other institutions. And because of their support, we're able to make programs like this possible. Especially this has been amazing that we're able to do this free of charge for everybody. So please visit the exhibitors, watch the short videos, and thank them for their support. A lot of people are connecting with community in the chat rooms, and that's wonderful. We hope you stay connected even after this summit is over. If you want to share about the summit on social media, please use our hashtag E3Summit20. And if you enjoy this program and you'd like to see more of it, your donations are always welcome at marfan.org/donate. Finally, Aortic Disease Awareness Week is coming up, and I have to say Cleveland Clinic, where Dr. Svensson is quite active in this whole area of aortic disease awareness, medical education about aortic disease, and they're great partners in Aortic Disease Awareness Week. The Marfan Foundation has a project where we raise our hands to raise awareness of the risk factors for aortic disease. So that information will be in the app and will also be on our website, and you will hear more about that as well next day or so. That's all I have. Dr. Svensson, do you have any final words before we say goodnight to everybody?
Well, thank you very much for hosting this session, and it's been my privilege to work with the Marfan Foundation for many years, and once upon a time getting the award in New York from the foundation. And I think it's important to realize for everybody listening and watching this that the disease of Marfan's has changed completely, and the life expectancy and what one can expect from after surgery is really excellent. And so there's hope for everybody. And thank you again for allowing me to speak to you. And I'm always available to answer questions if you have anything. So thank you for your time.
Well, thank you for your time tonight, Dr. Svensson. I hope you have a good night. And I wish everybody else a good night who is participating tonight. And hopefully we'll see you on another session tomorrow. Take care.
Good night.